Hello, my name is Lorez Meinhold, and I'm the Senior Policy Director for the Keystone Policy Center. It's a pleasure to moderate this panel discussion for Keystone Symposia and to welcome all of you who are taking time out of your busy schedules to participate. As many of you know, Keystone Symposia convenes some of the leading life science conferences worldwide. The virtual Keystone Symposia e-panel event is part of an initiative to bring more science to more people. And for this e-panel, we'll show first a previously recorded roundtable discussion. At the conclusion of that video, the panelists and I will come back live to continue the discussion and answer questions provided online by the global audience. At this time, I'd like to introduce the panel. We have Sean Ring from Editas. We have Dr. Vic Meyer from Editas Medicine. We have Karen Mara from Clark Atlanta University. We have Dr. Mary Houlihan from the Centers for Disease Control and Prevention, and we have Dr. Manu Platt from Georgia Institute of Technology and Emory University. Both Dr. Meyer and Dr. Houlihan are not part of the recorded discussion, but rest assured, we will be able to get their unique perspective when we're back here live. And so looking forward to that. And then I just want to remind people that you have the opportunity during the video roundtable and Q&A that follows, you can still submit questions online using the chat feature and Twitter hashtag VKS Sickle Cell. And I expect a lively Q&A discussion after the recording. So definitely, we can't promise that we'll get to all the questions, of course, but we will do our best. So now we'll show the roundtable discussion video, and we'll see you here back live for the Q&A.
So thank you all for your time today. Looking forward, let's jump right into the conversation. So Karen, what does it mean to have sickle cell?
To me, what it means to have sickle cell is, I guess, being born into a world with a disease you didn't ask for and learning how to live with it and grow through childhood, not being able to do everything in activities that everybody else could do, and needing accommodations, and having to catch up in school all the time from being in the hospital. But it also means that you have a good support system, because when you have sickle cell, you meet people and already have people in your family who are very supportive, because people with sickle cell are dependents, sometimes, most of the time.
Great. Thank you for sharing. Manu, from your perspective, what are the key factors that contribute to health disparities?
Well, I'd say the major thing is economics, period, right? Access to care, trusting the medical system, I think, is a very big one and a very important one. I remember when I finished my PhD, all my family wanted to call me doctor, which they should have. But my work was in cardiovascular disease. And then I would ask them about their doctor's visits and the things that the doctor would say, but they didn't believe. Or the other part about things they don't understand of what the doctor is saying also. And what I found with some of my family members especially is there's that one time when the doctor was disrespectful to them or disregarded something they said or whichever. And they were like, we're not going back. And I can handle this on my own. And so I think all of those things together make it such that people who are not able to access doctors, don't believe in accessing doctors, then experience the diseases, and it advances far beyond what it should if they had regular medical care. And I think that's the biggest thing about getting patients just to go to the doctor when they have an issue. Because we studied these things that are these health disparities, like breast cancer, for example, right? White women are more likely to get it, black women are more likely to die from it. And it's just not necessarily the biology that's so different. It becomes about care, access to care and treatment. That's what I believe is one of the major reasons.
Right. Sickle cell is one of the most common genetic blood disorders in the U.S., but federal funding doesn't always follow suit. Why, and what can be done about it?
Well, I'll take that question.
Go for it.
I guess there's not enough awareness because I can't answer why there's not enough awareness, but with other diseases, you'll see like they'll have things that going on at the city council or in the government office. They'll have events to raise money and raise awareness, and that's a big part of funding is being able to be out there. And you don't really see that with sickle cell disease. You don't really see awareness. You don't, even when it comes to like commercials for cancer on television, you don't see commercials for sickle cell and raising money for that on television. I've never seen one. So I guess it's just a lack of awareness.
It's amazing how many people that, you know, when I go and talk, and I do a lot of outreach as well, who I'm one of my opening statements, I know you think sickle cell isn't a problem anymore and that it's a cure. And then people are always surprised, like, oh, is it? Because it's one of these diseases we learn about early on in our like biology class, right? Because it's this thing. But I always call it this weird thing about sickle cell, right? The first patient identified with it was around long, it was in 1910. So that's what, 108 years ago in Chicago. We know the molecular cause, we know the genetic cause, we know all of these things about it. And then the drugs are just not there, right? And so you sit and wonder to yourself, with other diseases, once you know the genetics, once you know the molecular stuff, drugs start pouring out around it. And you know, you bring up a great point. When you look at these other diseases, and I have to say, the Sickle Cell Foundation of Georgia really educated me quite a bit. It's the most common blood disorder, as you stated. But what does everyone hear about? Hemophilia, right? And hemophilia has maybe, 15,000 people in the United States, where sickle cell has 100,000. And then to big up on that part too, then you do have to look at communities, I feel like, right? Hemophilia really got a lot of boost around the HIV/AIDS era, rightfully so, right? But then you also look at who it affects and what is the economic status of people that it affects. And then what kind of funds are those groups able to mobilize because of who it affects? Then you look at sickle cell, and as she mentioned in her opening, a lot of people with sickle cell are dependents, they're on disability, and just raising money is not coming from our communities for a number of different reasons. And so that's where you would depend on the federal government. But I think she brings a good point. If people aren't fighting for it and bringing awareness, then why would the feds think it's something that's still important?
Right.
And I do think there's a role for that within the industry that I work in now, as we think about gene therapy and gene editing products that are either coming close to being in the clinic or are actually moving into the clinic right now, and using that as a catalyst to help build some of the momentum around awareness.
That's a really good idea.
And how would we go about building that awareness in community if that's sort of one of the big issues to raise, sort of increase funding? How do we do it?
Whew. You got an idea?
I mean, we could have, there's the Sickle Cell Foundation. They could have a designated person hired in charge of doing awareness campaigns, city visits, different things. Or it could even be somebody to volunteer to do that, that position. But I've went to the government to do a campaign once out of, I don't know, I've lived here over 10 years and I've only done that one time. So I just don't know if they actually have a designated person or a group of designated people in charge of that aspect. Because I know, like, when they have studies at the hospital, you see a designated person in charge of going around asking questions, gathering information. So it's just like, is it the job of the patients, or is it the job of the foundation? Whose job is it to raise awareness, and how can we come together to make that happen?
Oh, that's great. I think we all have a role. So scientists, what is our role as scientists?
Scientists, I like to say we like to raise in my lab scientist activists, right? And I really pull that from the HIV community, because that's another part of my work, in that when that first hit, all the clinicians and the researchers had to be public advocates for their patients because there was all these fears and these other things. So I was watching that model work, and then how do they bring awareness and to stop stigma, right? And I think that's one of the other things to think about with sickle cell is there are people that have trait, and this is where clinicians come into play too, who everyone's tested at birth, and when people find out they have, or the parents are told they have trait, most often they forget about it and go on because there's a lesson that trait is benign. Nothing happens if you have trait. But I have friends who they have gotten married and had kids and were like, oh my goodness, my partner and I both had trait and we have a child with sickle cell. And they didn't even know they had trait. And these are my scientist friends, right? So if the scientists aren't kept aware, then how do we expect the general public to be? And so I think about it again in relation to HIV, and it's still a blood test. There's HIV campaigns of know your status. People should know their sickle status. Not that they should be like scared or afraid of knowing, but just so they would either make the appropriate reproductive decisions or to just be aware that if they are concerned about those reproductive decisions, that they might happen. And that's a campaign I think that we should start. But I did want to say the Sickle Cell Foundation of Georgia, they do have public information campaigns, but funding is very different for them than like the American Cancer Society and hemophilia. Everyone says to me, why don't you get grants from the Sickle Cell Foundation of Georgia? They don't give out grants. They spend all of the funds they raise on the clients. And that is where their money goes. And they are trying to educate, but you have to get people to care.
And another thing with the, they have this thing that I went to for many years called Sickle Cell Education Day. And it was really nice. You get educated, parents got educated. Like they would tell us things like how you just said, that people need to get tested, like knowing HIV status. You really do, because they even tell us as sickle patients, you need to get your partner tested. You need to make the smart decision, because even with my own parents, they didn't know that they had the trait. So it just so happened when my sister came along, oh man. So a lot of, especially the Black community, because it affects us the most, they are the ones who need to be tested, because that is why most of us are here, because nobody's tested, nobody knows, and then you're just having babies with another person as a trait, and then it's just getting worse and worse.
Right. And Sean, sort of, is industry's role in raising community awareness? What's its role?
Yeah, I think industry does have a really important role to play, both in partnering with organizations like the Sickle Cell Disease Foundations that do exist, and working with them to bring the resources and kind of the megaphone that we have around our industry and around some of our technology, and using that to promote the awareness.
So in 1994, life expectancy for sickle cell patients was 42 for men and 48 for women. And by 2005, it's actually going in the wrong direction. It dropped to 38 for men and 42 for women. Why are we moving in the wrong direction?
The year that you give, it's not necessarily applicable to the year, but I think about the Affordable Care Act and when it passed and what was associated, and then the Medicaid expansion that was associated with it. And it's an interesting thing. The American Heart Association overlays graphs. You can do new HIV infections. And you see where all the states that rejected Medicaid expansion are all states that have these huge health disparities, right? Sickle cell is huge here in the South, Georgia, Alabama, Mississippi, states that did not participate in the Medicaid expansion. And you just think if you want to help people, and particularly as she mentioned, again, I love that she mentioned, most of them are on dependence, they're on disability because they're in chronic pain. And so there's that, again, access to healthcare and the federal government's role in providing healthcare to each of its citizens. And when you don't, people don't do as well.
Is there hospital avoidance too, Manu, you think? Are people...
I'll let her answer that question. That's a good point.
Yes, there definitely is, because there is something going on within the sickle cell community that I don't think that the world is aware of. Sickle cell patients more often than not are depicted as drug addicts when we go to the hospital. And this is why, and I'm saying this, and this is the same thing that all my friends that I know have sickle cell all go through the same thing. We have been on medications like oxycodone since we were children. So over time, it's either our body becomes immune to it or we just don't like taking it for whatever various reasons. And then we try not to go to the hospital too often, but once your body gets into so much pain, then you have to go to the hospital. Like for me, myself, I don't like taking oxycodone because it makes me nauseous, and I've just been taking it so long, it has a lesser effect. So when I go to the hospital, sometimes there are doctors who are understanding of my disease, and sometimes there are doctors who aren't understanding. And I've been told before by doctors, oh, we don't believe you're actually in pain. You look perfectly fine to me. Wow. And it's just like, people with sickle cell aren't going to be bawling, crying every time we're in chronic pain, because if you burn yourself, at first you're going to cry, but then after a while, you're going to get used to it. You're not going to just keep crying, even though it still hurts. So there's a misconception that just because you look fine, that you're just faking being sick. And so a lot of times, stress is a factor to pain. And a lot of times we get stressed out by the doctors and nurses telling us that we're not in pain and telling us that just making us feel uncomfortable in an environment that we come to get help. So there is definitely an avoidance of patients going to the hospital.
That's really powerful to think that you would not go to the hospital and actually stay home and bear the pain versus going and having that type of experience. Thanks for sharing that.
Even interestingly, I've met people with sickle cell that are doctors, they're physicians, and they get treated the exact same way when they go to the ER. And they are like, I'm a physician, and you think that I am here for the drugs and for the pain? Imagine, right?
Yeah, it's crazy.
So how do we create the change with healthcare professionals and policymakers to increase access to care, to change that trend?
Can I take
Please.
that one? I think there are 3 things I want to touch on. One is assigning doctors who actually know what they're doing to the patient. There's a time I was in the hospital and asked the doctor, does she know anything about sickle cell disease? And she admitted she did not know anything about it. But you're my hematologist doctor and you're the one prescribing my medication. It just didn't make sense to me. And another thing is, as he was touching on accessibility, like in people being dependents, not everybody with sickle cell disease has somebody to depend on. I know people who are borderline homeless with sickle cell disease because the government's not doing enough and they don't have family that even cares about them. So it's like, if you're having to pay $4, riding the MARTA one way is $2.50. But for the mobility bus, it's $4 one way. Some people don't have money for that. So how can you go to your doctor's appointment if you have to pay $4 to use that service just to go one way when regular people only have to pay $2.50? So that's another thing that ties into the accessibility factor, and just having people that care. Because a lot of the time, like even in childcare has the better care. Adult care, they treat you differently. So when you're in childcare, there are also people who will treat you like you're just anybody, and that's a problem. You actually need doctors and nurses and nutritionists who care and don't look at you as if you're just here for the drugs.
So you touched on this a little bit about the treatment care outcomes as you're transitioning from adolescence to adulthood. Are there sort of other things that sort of are challenges as people are moving between systems?
Well, here in Atlanta, and this is, again, not as a clinician, this was also surprising news to me. It's great to hear from your perspective. Again, I've heard this, that the pediatric, so if you look at the statistics for sickle cell, where you see the greatest risk of death is at that 18, 19-year-old stage when they are asked to transition from pediatric hematologist to adult hematologist. And I used to, and when I first got into this field, I was at a big sickle meeting and I asked, there were several pediatric hematologists there and very few adult hemocs. And I asked one of them, and it was this black woman, I was like, what's the difference? Like, why do they need to go to another doctor, you know? And she said, and this is an interesting story, it was just one case, but she said to me, she said, well, yeah, I'm a pediatric hematologist. She said, but once I had one of my 14-year-old sickle cell patients showed up pregnant. She said that I had no idea how to manage sickle cell in pregnancy. And so I got it in that example of why there was a need, but I think there's many other times where I'm not pregnant, I'm not doing anything different. I'm just still your patient. And so I don't know how to resolve that. And if it's an insurance-based thing, or if there's other things that could be lobbied for, that could be used to make a difference. But the other thing that I hear about the clinical preparation part also is that, you know, if you're in a concentrated area, but I know I'd love to hear your story about this either. If you're in a concentrated area, like Atlanta or certain parts of Florida or Washington, D.C., where there are places that used to have these federal funded sickle cell centers, which also may be another reason that the life expectancy began to drop. They used to have these federal funded centers that ended around the 90s. Then maybe you would have a doctor who has done something with sickle cell in the past. But if not, and they see a sick person with sickle once every 5 years, she mentioned those docs had no idea. And one thing that, again, Sickle Foundation of Georgia, they play a major advocacy role. I've been on the phone talking with them about a project. They would have to click over on call waiting, be like, Dr. Platt, we have to call you back. So-and-so's having a crisis, and they're rushing this one to the wrong hospital. And if they take them to the wrong hospital, they're gonna do the wrong thing, and it's risky. I gotta call you back. And how crazy is that the wrong hospital for the most common blood disease in the United States may do something terrible to kill that patient, right? So, I'm sorry, back to Atlanta. And so in Atlanta, there was at one point 1 or 2 adult hematologists seeing thousands of patients in the Atlanta region. But for the peds, there were like tens of clinicians. Maybe the balance, maybe it doesn't earn as much money, maybe it's not as interesting. I'm not sure what the motivation is or if it needs to be incentivized and how to then do that. So that because if we do our job as healthcare professionals and researchers, we hope the pediatric clients will become adult clients and then maybe become gerontology,
Right.
hemonc clients.
Right. Well, can I say something on what you said about the transition? I could probably explain why the most death is probably between 18 and 19 after the transfer. When you transfer, normally you're supposed to be transferred at 21. But for whatever reason, the child care starts transferring people at 17. So that's around the age that you graduate from high school. So imagine you're transitioning from your parents taking you to all your appointments, making sure you're doing what you're supposed to do. And then now all of a sudden you have 1 day of education and transfer knowledge. And then it's just like, okay, bye, you're off to college, you're off to adult by yourself. And then you're not going for your appointments. You're not taking your medication the way you're supposed to. You don't have the proper education on how to take care of yourself for yourself. And that's probably a big reason why that is. And also the facilities are way different. You have Eggleston, Scottish Rite. Those are the 2 big ones down here for sickle cell with children. But then once you're transferred, the only hospital that they really know of to transfer you to is Grady for an adult care.
So what would be the best way it seems like we need to refocus on sickle cell and put some attention and detail, especially to adult sickle cell. How do we do that? How do we change healthcare professionals to focus on this? How do we get policymakers to think about this and dedicate funding to this?
Yeah, it's a good question. Yeah, I think it starts with transparent communication like this, right? Really putting the issues out on the table and not sugarcoating them, and bringing a group of people together around that table to have a frank discussion about what needs to change and what people like Karen are, how it's impacting their life. Because I think it's really powerful to sit here and hear this, and hopefully what you can do is use those forums to kind of build the momentum we need. It's also finding people within NIH or within the legislature that have either a personal connection or have done some type of connection with sickle cell disease. One example comes to mind recently. Our CEO of my company, Katrine Bosley, was presenting to the Senate Health Committee. So that's the Health, Education, Labor, and Pension Committee, comprised of senators. And Senator Tim Scott of South Carolina was talking about his enthusiasm for CRISPR and his optimism. And in particular, he mentioned sickle cell disease. And so I think it's finding people like Senator Scott and others within NIH. I know there's a Dr. John Tisdale who does a considerable amount of clinical research. Vince Bonham is doing some work as well around CRISPR and the attitudes and awareness within the sickle cell community. So it's bringing people like that to the table, along with people like Karen who can share her experience to build that momentum.
I think the other thing that has to happen is families have to be transparent and talk about it. And even people who have the distant cousins that are, need to talk to the person who's going through it so that they can also take that information. I think it's about the public information campaign where if you get a whole family tree behind it, then in all of their different communities, they are promoting it and telling people. And then it becomes a thing again it's still here. It's not cured. And as you mentioned, life expectancy is going down. This is America. Like, what are we talking about? We can do better than that.
Right. Go ahead.
Sorry,
please.
I was just going to say, actually, in other rare diseases that I've worked in, I've actually seen that a similar issue where people actually don't want to talk about it within their own family. They almost want to hide it a little bit because sometimes there's some shame associated with it, or am I going to pass this on to the next generation? So I think there's a lot of dynamics in there that probably play out and don't end up having that frank conversation
And
take place.
with sickle cell, very specifically, if you don't talk about it, yes, you will pass it on to the next. That's what it is. It's a genetic disease, It's so ridiculous. I'm sorry.
You talked about this being an issue, not just, it's a U.S. issue, but it's also a global issue.
Yeah.
What is the connection between sort of what's going on here and what's going on globally?
One of my new mentors in sickle cell research is Dr. Michael DeBond, who's now at Vanderbilt. And he's built his whole career around silent strokes and sickle cell, and he's amazing, well-renowned, National Academy of Medicine, all these things. And we invited him to give a talk at Georgia Tech recently as a distinguished lecture. And one thing he said that he was challenged about, he met some Nigerian doctors and they were like, "You think you do sickle cell?" And he tells the story better than I do. He said, "You think you do sickle cell? Do sickle cell in Nigeria. Then tell me that you do sickle cell." Because that is where it is the most prevalent. But again, when I do this talk about health disparities and being scientist activists, it's always this thing about how do you encourage federal funding for projects that are health disparities? Because if they're health disparity, then there's some people who just don't care. And so I always say that things that are health disparities in the United States are usually global health problems. So sickle cell health disparity here, global problem. What's the problem in the world? There are 300,000 babies born every year with sickle cell disease globally, and 90% will die before their first 5 years of life. Crazy, right? Mm-hmm. And so when you go over there, it has to change the way you think about it. And that's why I think clinicians, engineers, plus public health experts, plus cultural experts all have to partner, because it's beyond just coming up with a drug, which we still need more for sickle. That's a huge thing. But then you have to think about how do you do that in a low resource setting, or in a setting where there's even less access to care than what our disparate health population in the United States have. And what it requires, I'll say for engineers, so one of those, is you really have to think outside of the box. Like, it's not like, well, if we could just get the usual technology we use here to work, it would be great. You can't think like that. What will be allowed under these governmental rules and under this access to drugs that we could do here? And that's why I think talking about it more brings new ideas to try to solve these problems, but also awareness of what's happening globally.
Yeah, I think it's a really important point, because you look at the types of treatments that we're trying to bring to market, and one for sickle cell would likely be a part of a stem cell transplant. Right. So you think about the context of needing to have the infrastructure, the healthcare infrastructure, to facilitate a stem cell transplant, and then have this be part of that. So even thinking about it here in the United States, there's likely only to be a handful of centers that would actually have the proficiency and the technical capabilities to actually administer our treatment and be trained on it, right? And that's here in the United States. So it's likely to be compounded with the complexity of medicine that's coming. So I think starting that conversation now, as you mentioned, and bringing those people together to start thinking about the infrastructure that needs to be in place in order to support access to medicines.
I think it's a great role for industry to play. I mean, as you mentioned, I think that is where you all really, you've got all the experts that can think about it. You've got the funding. I mean, assuming that it can be spent on those things. And I think that's where industry plays a major role than NGOs or whatever.
Right. And I mean, I work for a 130 person in Cambridge, Massachusetts. But
when you get bought.
Yeah. But point taken is, and I think that there are a lot of large pharmaceutical companies who have partnered with, frankly, organizations that specialize in the type of access that you're mentioning. But more needs to be done for sure.
So we've been talking about access. It's really been a little bit about sort of, do we have the right providers with the right knowledge? Another big piece of access to care is the cost. So we can develop the treatment, but then how do we make sure that people really need it, can afford to get it? So how do we address that cost issue as well?
So I always like to liken this back to the HIV community for a number of reasons. What's been interesting and this also gets to an ethics discussion also, right? Cost for sure. What's an interesting thing, there's so many interesting studies about HIV and how it became this problem that people are solving with global teams. We've made great strides there, so it's fantastic. So let's apply it to some other diseases. But for example, when we think about clinical trials that industry or the companies are running to get their products approved, for many of the antiretrovirals, they, of course, running tests in sub-Saharan Africa and other places. For great reason, there was a huge need for the countries and they would be highly affected. But then the question becomes, well, then once the drug is now tested on them and now we know it works, can they have access to that drug, right? Because if it's priced at a point that they can't afford it, and you would see a lot of them still getting like the older antiretrovirals, which it really raises some ethical questions of if you are testing on a population, they should have access. But I think that's a great place where industry can rethink a model where if a country is open to being clinical trials for, there should maybe be a relationship or some contract or some discussion about, then we will also, after we are approved, you all get it at a certain price, cost, accessibility, because you played a part in us getting it to the pipeline. I think that could be some magical agreements that maybe World Health Organization or other people could help facilitate, that makes it where the country gets the help, but also is not being used as like the test bed. My thoughts. But.
Yeah, no, and I think it's a very important point. And I mean, I think for the organizations that I've been a part of and what we're doing now, I mean, we think long and hard about where to go with our clinical trials, because in which countries to go into, because we want to make sure we're making a commitment to have that product available there. But I think it's a really important point. And I mean, we have a lot of work to do here in the United States too, as you know, around just access. And in particular, one of the things that we work on quite a bit is, so you think about how people access medicine today. It's typically in a chronic setting where they're going to their pharmacy and getting it on a weekly basis, bi-weekly basis, paying their copay. They take it home and they take it. Our idea is single administration, durable effect, right? So our system isn't designed, insurance companies aren't designed to reimburse for medicines in that way. So we're working with a lot of stakeholders now, both within the patient community, within the health insurance community, within the Medicare, Medicaid community, to figure out this new model, right? And then once that model is established, we would envision having a set of services where we could work with patients who are looking to access the treatment and help facilitate that access, because I think it is really important, and it's exceedingly complex, and it's only getting more complex as people transition from one insurance company to another, and all of the things.
And I wonder if you could even do, the insurance companies can run the actuarial tables that, like, one treatment that stops it will stop all of the visits to the ER that she or her friend or dog, where they're sitting in the ER waiting for hours. And that cost that's associated there, could you maybe make that pay off?
Yeah, well,
right?
that's the value argument, right? And that's exactly why it's really important that we understand at the deepest level we can the impact of the disease on the individual patient, right? What it means from the time they're diagnosed and the time they're born throughout their life. How are they accessing healthcare, right? So that we can truly understand what type of impact it's having, and where we could actually make an impact with an intervention and provide value.
And I think it's huge with sickle, and you could cover it next, because people think about sickle, they just think about the blood, right? But remember, red blood cells go to every organ, every tissue in our bodies. So what happens, there's multi-organ damage. So when I'm telling my friends about it, like why they should study it, people I know who study bone disease should study sickle cell, because they have increased hip replacements when they're in their late teens, early 20s. They, of course, the lung pathology, that's the main problem, the acute chest syndrome, the strokes and the brains and neurologists, gastrointestinal, kidneys, like it affects everything. So if you could stop it early, how much exposure to the healthcare system and money
It brings
can we
tremendous
save?
value to the patient who's received it, and then value to the system as well by mitigating the access to care.
It seems like one of the first things that also we need to rebuild trust, that healthcare will be there. What do you think, Karen, why don't you take a first cut at this? Because you've experienced the system firsthand, and it isn't from your experience, it doesn't feel like it's very trust building. What does the system need to do to really rebuild trust with community?
In order to rebuild trust with community, there needs to be total transparency on both ends. Like when I say total transparency and mistrust, I'm going to give an example of how mistrust forms. And this is a recent example. Nowadays, there are a higher increase of people taking oxycodone, Percocet drugs, and it's causing problems to the point where a lot of places don't want to prescribe it, or a lot of pharmacies don't want to carry it. The other day, I went to my home pharmacy, and it moved. So there's new employees mixed with old employees. And I brought them my prescription for oxycodone because I was having pain for like a week straight. And then, so I'm asking the lady, do you guys have this? And she says, no, we won't have it for another week. If you give us this paper, we can order it. We'll have it in a week. So I'm like, dang, I can't wait a week. And I had called at least 10 different pharmacies. Nobody had it. This is not even the highest dose of oxycodone, but it's just the epidemic going around is making it hard for anybody. So 10 different pharmacies rejected from all of them. And then it got to one of the last phone calls, and the lady says, your home pharmacy should have it, because the way the system works is if there's nobody in that community ordering this medication, they might not carry it. But if they do have a patient with at-home pharmacy in this community, then they should have it. So I'm like, that's strange, because I went to my home pharmacy. That was the first place I went this morning. So I called them back and I said, I asked for one of the pharmacists that I knew, because the lady who was at the window, I never seen her before. So I asked her, and she knew who I was. She was like, yeah, Karen, yeah, come, you got the paper, just come up here. And she's like, let me check. And she went and checked, and they had it. So I come up there, I'm like, this is the first place I came to this morning. So you looked at me and told me that you wouldn't have it for a whole nother week, and you guys had it in your facility. I wasted gas, time, and pain trying to find this medication. For what reason? Did you just look at me and racially profile me and you didn't even bother to go check? So that happens more often than not. And that is where it needs to start.
So when we think about gene editing and CRISPR technology, it's happening in food, it's happening in conservation, it's happening in health. There isn't necessarily a lot of trust. How do you build trust with that technology?
Yeah, it's a good question, and I think it starts with actually doing a lot of listening as opposed to going out and doing a lot of talking, and trying to understand what people's viewpoints are on the technology, what their awareness is, and understanding, and then engaging in a respectful dialogue, right? And being as transparent as we possibly can about where we are, what we're working on, and what our intentions are with it. So it's building that trust from the ground up, and I think, for us, the way we think about it is maybe a little bit different as well. Is we like to go to the table with to speak to people who maybe have a different point of view than us on our technology. Because if you surround yourself with a group of people who are like-minded, you really don't actually evolve the conversation. And so we spent a lot of time doing that. We intend to do that. And again, to Karen's point earlier around the need for transparency, we fundamentally believe that.
Can I ask Karen a question? So just when you said transparency, you said on both sides. So what do you mean on both sides? So I get from, so give me the other side.
Oh, okay. This is important too. Okay, from a patient point of view.
Yeah.
Okay, a lot of the time, starting early on in age, this begins when you're in childcare. The doctors and the nurses will ask you, are you taking your medications? Now, as a child, if you're told you're doing a bad thing, you're not taking your medications, that child's going to learn how to start lying and saying that and that goes into, this can help with you guys' research, because a lot of the times people are lying and then they're wondering why the medication is not working. It's because the person's not actually taking the medication and they're saying they are, and they're writing the results down as, well, maybe she needs a higher dosage. Maybe something we're doing isn't right. No, it's the person is lying and saying, they're taking the medication, they're not, because they don't want to get in trouble, because sometimes your doctors and nurses feel like you will be receiving a repercussion. And I had a conversation with my dietitian yesterday or the day before, and she was the first person who ever made me feel like there'd be no repercussions for me not taking my medicine. She just wanted to know so she could help me. And I was like, you're the first person who ever made me feel that way. And the first person that made me feel like I could tell you the truth if I am or am not taking my medication.
So created that safe space for you to be able to share.
Because that's interesting, because I was going to ask a question about, because you didn't want to be stigmatized at the pharmacy. So if the doctor was challenging you, like, are you really taking it? How that would be upsetting, but I get it. They make this safe space as though whatever the answer is. Oh, that's interesting.
Well, and maybe if you wouldn't mind even sharing a little bit more about sort of why a patient might not take medication, because I think the assumption from the medical side, the medical community, is a person gets labeled as non-compliant, and that they're not following my instructions. But when you talk to other people with sickle cell, what are the biggest reasons why people won't be taking the medication?
Well, this goes into, there's not enough options, because sometimes medications will make you nauseous, make you dizzy, make you feel just terrible, like you can't go through the day. And then when you tell your doctor you're not taking medication, instead of asking, well, is it making you feel worse? Is there anything we can change? They just, well, if you don't take it, then they list all the bad, terrible things that are going to happen to you, and it just creates a fear. And that fear is what makes somebody not want to take their medication. Fear of the side effects, fear of there not being any other option. Like, if you get nauseous from hydroxyurea. What other medication like hydroxyurea is offered? Nothing that I know of. So I guess that could be a big problem.
Well, as we think about getting to solutions, whether that be sort of additional drugs or technologies, how do we ensure voices are included, patient voices are included so that it can be used, it can be affordable, it can be accessible? How do we ensure scientist voices and industry voices are included? How do we do that?
Creating forums like these, I think is a starting point. But I think it's building on these conversations, right? And I do think it's making sure that everybody is around the table. All of the different stakeholders are who have either a professional kind of interest or personal interest in this are around that table, and we're building that dialogue together.
And I would say empowering the patient voice, right? Inviting them to the table, having them, asking them to be at the table and to speak up. And then again, to not challenge anything they say, to just listen, like you mentioned earlier, and believe what they say. But I love hearing the perspective, because I love your question. So I'm just like, taking medicine, you know, it's good for you, but there's things that are happening to you that you live and you feel and experience that you're like, yeah, but it's my only option. So I'm just supposed to just deal because it's the only option. That's powerful. And I think listening and believing them when they talk. And I think for the federal government, believing scientists when they show you data, and it's data from federally funded research programs. And please, Congress, listen to the scientists.
Well, and I think that's a big issue now, science, and how does science inform policy?
Right.
How do we raise science, evidence base into solutions going forward?
You know, there's a movement post the Science March, the March for Science that happened, where people are really trying to recruit scientists to run for public office. Because I think the numbers of scientists that are in U.S. Congress, right, there's a few medical doctors, I believe. But it doesn't have to be at the federal level. It could be, of course, at the state legislature and even city levels. And they're trying to recruit scientists into public office, but a lot of us are weirdos, right? So not the best politicians. But I think if you can find those charismatic ones and that have a desire to do it, or people who have finished one part of their career and would like to do the next step, I mean, maybe that's the way, that you have a voice that actually believes the scientist. But you would think, if I put my money into something, I'm going to trust what I get out of it. But that's not how it works. That's one thing I could think of.
Yeah.
And I think we've found ways to interact with policymakers who do and are willing to listen and want to better understand, just given the potential of the technology that we're working in. So I'm optimistic that those opportunities exist, but you need to go out and seek them, right? And going on your comment around scientists as politicians, we actually had an interesting conversation with a member of the clergy, actually, who is actually a PhD and runs a lab actually down at Providence College. Father Nick, as he goes by, and he was particularly interested in learning about our research and some of the bioethical components of the conversation. So I think there's a lot of different groups out there that are interested. It's figuring out how to engage with them the right way, and like I said, I think listening. Not just simply waiting to talk.
Okay. Any last thoughts before we wrap up? Karen?
I got to think of something.
Anything
Anything
that you want to say that I didn't ask you about, that you feel like it's important people understand about sickle cell?
I think the very, very most important thing about sickle cell is having people who care working with the patients. Because I just lost a friend who was at the hospital and nobody even knows what happened to her. And she had sickle cell. You don't even care to tell her family what happened to her properly, that they have to pay to find out for themselves. That's a lack of care, and that's where it starts.
That's good. I would like to just build on that and just, one thing I try to impress, I run a very inclusive lab and these other things, and I speak about, is they're people, right? Like, if you just have a heart, they are people. They have something they were born with. It causes them pain. They're people in pain, right? Not always in pain, and they live these wonderful, robust, full lives, but they're people. So why would you just try to ignore them or act like you just don't care? But I say that, and then again, I'm going to counter it with the HIV thing again. Same thing, people with HIV, they're people too. But you see people respond differently. Well, quote, they got it by doing something. They're people, right? And people with sickle cell, they didn't do anything. And I just feel like if we just start looking at each other, no matter what color, race, creed, health status, they're people. Oh my God, right?
Yes.
Anything else you want to add?
Hard for me to add anything to either of those.
All right, thank you so much.
Thanks for having me.
Thank you.
We're back live. Before we continue the discussion, we'd like to hear from both Vic and Mary. Vic, could you share your thoughts from a CRISPR perspective?
Yeah, sure. So maybe a couple quick notes on CRISPR. CRISPR-Cas9 and CRISPR-CPF1 are both relatively new technologies. They have actually only been around for about 5 years, where they were shown to be first useful and active in human cells, which is, of course, where we need them to be to create therapies. At its core, CRISPR is an incredibly flexible, efficient, and specific genome editing tool, which allows us to go in and make specific changes to the genome in a cell. It's really taken the research world by storm. New biology discoveries and new uses for the technology seem to be published on a daily basis. So it's caused, I think, a lot of excitement in the field, and it's spurred a lot of activity in the therapeutic field as well. It's been called the Swiss Army knife of genome editing, and I've also heard it called the discovery of the century, although it's kind of a new century, so I don't know if that's going to hang on for the long haul. We're only 18 years in. But I think it's spurred an amazing amount of research and an amazing amount of scientific advancement. In terms of sickle cell disease, we think CRISPR is a really promising way to address the problem. It's important to understand that it's not the first gene therapy or genome editing approach that's being tried for this disease. But because of its efficiency and flexibility, it allows us to test many, many hypotheses preclinically to identify what we think are going to be ultimately the best strategy for providing a durable, efficacious, and safe solution to this important unmet medical need.
Great. Thank you. Mary, can we have your thoughts from a CDC perspective around sickle cell?
Sure. So first of all, thank you so much for inviting me today. I was going to take a few minutes and just give you some of the activities that are taking place at CDC, and then also a few of things that are taking place on a more national level. So first of all, I wanted to let you know that we do have numerous health education and health communications materials, and these are all available on our website. We have things like fact sheets to help people gain a better understanding of sickle cell disease, the underlying genetics of the condition. We have pamphlets about how to talk to teachers and school officials if you have a child with sickle cell disease. We have a toolkit with lots of materials for people who want to know more about sickle cell trait. We have videos about transition of care. We have a national resource directory in case you're traveling or moving somewhere different from where you're currently living and you need to find new providers or new community organizations. So in addition to those materials, we also have 3 large projects that are going on with external partners. We have one that's with the Association of Public Health Laboratories, and that's the group that designs strategies to address changes in the field of newborn screening testing, and also works with newborn screening laboratories on matters related to quality control and proficiency testing. So with that group, we're looking at ways to improve screening for sickle cell disease, both within the United States and externally. As you probably know, there's newborn screening in the United States, but there are people who were born after newborn screening was implemented or who are moving here from other states. There's also lots of work going on globally with screening, and so trying to increase the materials that are available for that. We also have a project that helps to improve outcomes for sickle cell patients who receive blood transfusions. And so transfusions are often a part of the therapeutic management for sickle cell disease. We know that probably somewhere in the order of 90% of adults with sickle cell disease will receive at least one transfusion as part of their therapy. But in most cases, these transfusions are really helpful. They can help reduce the occurrence of stroke in children and things such as that. However, we also know that these transfusions can result in additional challenges for patients over time. And we know that one of the best ways to reduce these complications from transfusions is for individuals who need a blood transfusion to receive blood from others within their own race or own ethnicity. And so having a lot of blood donors from the African American community is important for individuals with sickle cell disease to try and avoid some of these complications from the therapeutic transfusions that they do receive. And so we want people to know, if they're looking for ways to help the sickle cell disease community, help their friends or family members with sickle cell, one of the really helpful things you can do is to give blood. It greatly increases the benefits of transfusions that individuals receive. And then finally, we have a sickle cell data collection program that's taking place in both California and Georgia. It's a program working with our partners in those two states that allows us to collect information from a lot of different sources. So places like newborn screening, hospital or emergency department records, death records. And by collecting that information, we're hoping to do a better job in understanding the disease. So we can use this information not only to understand where people with sickle cell disease live in these states, but also where there are doctors who are taking care of individuals with sickle cell disease, where there are emergency departments that see high volumes of patients with sickle cell disease, how many times a year people go to the hospital, information like that. And our ultimate goal with that project is to use that information in ways that it can improve healthcare, improve health policies, so that people with sickle cell disease can eventually live longer and healthier lives. So that's just a brief overview of the projects that we have here going on at CDC, but I also really want to stress that there is interest in sickle cell disease right now at much higher levels across the board, both at a government level and within the medical community. So there's other agencies, obviously National Institutes of Health, groups like that have been working on sickle cell disease for a long time. But there's now interest coming from places like the Department of Health and Human Services. The gentleman who's our current Assistant Secretary of Health, Dr. Brett Giroir, as well as the gentleman who's our current Surgeon General, Dr. Jerome Adams, have both come forward and said that not only is sickle cell disease a big interest for them on a professional level, but they also both have a very vested personal interest as well. So that's really exciting for us to hear that there is such interest and such plan for action at these high levels. We also know that there's groups outside of government who are very interested. We're seeing some of the national organizations playing a big role. So, for example, the American Society of Hematology, the professional organization for hematologists, for hematology researchers, for the first time ever, they have decided that they are going to place a lot of their resources and efforts on one single disease, and the disease that they have chosen is sickle cell disease. So they have a lot of products that are coming out. They're doing a lot of work both within the United States and globally to try and improve care for sickle cell. There's also work being done by the American College of Emergency Physicians. They have a work group that's putting plans together. So just in general, this is a really important and exciting time for sickle cell, and I'm so glad to see events like this taking place. Thank you.
Well, thank you both. At this point, we want to continue the discussion and get to the questions submitted online. So we're going to dive right in. Manu, what is the research trend in drug discovery in sickle cell?
Yes, thank you for that question. And again, thanks to all of you who are watching online. There's the one drug that has been the longest that has been currently prescribed to sickle cell, which is hydroxyurea, which it works by turning on fetal hemoglobin back in people with sickle cell. And, we all have fetal hemoglobin while we're developing in our mother's womb to pull oxygen from her blood, but we turn it off when we're born. But it's been known for a long time that fetal hemoglobin actually stops that sickle polymer from forming. So in doing that, if we can turn that expression back on in people with sickle, then they tend to have less complications and reduce symptoms. That's the one that's been out the longest. There's a new drug that was approved, I think, last year, the first drug in 20 years for sickle cell. That was an L-glutamine. Controversial about how useful it will be to many patients. But over the course of the time that we've been in the research field, we've tried anti-sickling agents and a whole number of other targets to help these individuals. But now the big ones are really places like where the CRISPR are coming, where stem cell therapies are really being targeted these days. What also is interesting about thinking about sickle cell in the United States versus in the rest of the world, a big difference with sickle cell versus some of the HIV/AIDS work, as I mentioned, is for HIV/AIDS, there's a large number of antiretrovirals that are available. And in the developing countries, they have a more reduced number that they are able to get. That's not the case for sickle cell because there's such a low number of drugs that are even available to prescribe to patients. So that's not an unfair advantage that we have for sickle because we do need more drug targets that are in the patients.
Great, thank you. Mary, you talked about in your overview data collection and the work that CDC is doing. Why is data collection important in drug discovery and sort of other work related to sickle cell?
Sure. So I think as Manu alluded to, and as hopefully a lot of people know, there are a lot of therapeutics that are coming out, a lot of pharmaceutical companies, in addition to the work that's going on with CRISPR, really getting into the sickle cell game these days. Which is wonderful. But one of the challenges with sickle cell disease is finding the patients who are interested in participating in clinical trials. It's challenging because, unfortunately, not all patients with sickle cell disease have the luxury of going to a large clinical center. Many of them go to primary care physicians, or many don't have even primary care physicians and receive a lot of their care in the emergency department. So data like ours really enables a great overview of the entire sickle cell disease population, not just those who are in clinical centers, not just those who have certain types of insurance. And so by using data like ours, it helps to identify where all patients are, where all of the doctors are who are taking care of these patients. So those doctors who are seeing 2, 3, or 5 patients, but maybe those patients would like to be a part of clinical trials as well. And then the other benefit of data like ours is we've been collecting this data for a long time. We currently have information that goes back to 2004. And so that's allowing us to establish a baseline of what the health for individuals with sickle cell disease looks like before all of these new drugs or before all of these new therapies come to market. And so we'll be able to see kind of how things were pre-new therapeutics and then how things look as new therapies hopefully do come to market and hopefully are available, and kind of what impact that has on the population as a whole.
Great, thank you. Karen, speaking of sort of the drugs and sort of the different pieces, pain management is a big piece and a big part of living with sickle cell. Karen, can you maybe share your experience of how you manage pain?
I start off with trying to keep warm. If I'm feeling a crisis coming on, I'll try to wear warmer clothes to keep my body temperature warmer. And then if that doesn't work, I'll try to take my prescription pain medicine. And if the pain is too much, that the pain medicine isn't working, I'll go to the hospital.
Okay.
And that's what I do for my pain management.
That's great. Thank you for sharing, Karen. So I'm going to switch it now a little bit back to CRISPR. Vic, could you talk a little bit more about the CRISPR technology, and is it specific when we're thinking about sickle cell, specific to the individual, or is it a technique that fits all?
Yeah, so for sickle cell in particular, the technology is going to be applicable to all the patients that have the sickle cell mutation. In general, when we think about using CRISPR as a therapy, there are sort of 2 general situations or circumstances. One where you're going in to try to correct a certain mutation. In that case, the approach would be specific to a given mutation. And as I'm sure many of you know, there are many diseases that are caused by many different mutations. So in those scenarios, you would have to make a different therapy for every individual mutation. As Manu pointed out earlier in the Q&A, we all have a form of hemoglobin called fetal hemoglobin that is important during development and that gets shut off after we're born, and beta globin takes over. And so we have a natural part of a genome that's just inactive as we develop. And if you happen to have the sickle cell mutation, you get sickle cell disease. So what a lot of the genome editing approaches are working on is actually reactivating that fetal hemoglobin. And so it will be broadly applicable.
Great. And then Sean and Vic, how close are we making CRISPR available to patients? And what is being done to establish the sickle cell disease endpoints?
Yeah, sure. I can take this. So I think, as Mary alluded to in our earlier comments, there's actually quite a bit of activity in the space, both from the gene therapy and gene editing approach, both kind of in the early development stage as well as actually moving towards and in the clinic. A quick search of clinicaltrials.gov shows that there's 7 different trials right now using these various approaches as part of a autologous stem cell transplant. So it's difficult to say when all of these, or any of these for that matter, would be available broadly in a commercial setting to patients. But there's certainly a lot of momentum and a lot of reason to be optimistic.
Great. Vic, why can't we still completely cure the genetic disorders and diseases after having a well-developed human genome sequence?
Yeah, so really good question. The way I like to think about it is the genome essentially has provided us a map, and what we're doing now is working out the directions and sort of building the vehicle to get to where we need to get to. So sequencing that human genome, it's really provided the foundation for understanding disease and setting the stage for providing therapies. And that's been a really important first step. What I think you've seen happen in a field that's growing with a ton of energy behind it is the idea of sequencing patients and sequencing populations to identify mutations that now cause a disease. So once we have the genome, we have to understand what are the different genes and mutations that contribute to disease, be it a single allele-driven classic sort of Mendelian disease or a complex disease. There's over 9,000 diseases that we've now understood at the genetic level. So I think we're building our knowledge base there. But I think when it comes to making a therapy, and particularly a therapy that works at the level of the genome, so to correct the mutation or to compensate for the mutation at the sort of source of the disease, which is at the genome in many cases, you really need to develop 2 important things. The first is we need genome editing technologies that can make the right change or changes. And secondly, and importantly, we need delivery technologies that are appropriate, efficient, and safe for the tissue of concern, so the tissue that we're looking to treat. CRISPR is, as I articulated a bit earlier, is an important addition to our genome editing toolbox, and I think it really has sparked a lot of investment and research in understanding and working on genetic diseases, and so I think this has been great. On the delivery side and on the gene therapy side, it's actually been an amazing couple of years if you've been in this field. We've seen major advancements for both in vivo therapies, so therapies that are injected into the patient, and this is exemplified by the approval of Luxturna for LCA2, which is an inherited retinal dystrophy. We've also seen 2 approvals exemplified by Kymriah and Yescarta for leukemia and lymphoma for cell therapy. So we've had 3 gene therapies approved over the past 2 years, and these are the first 3 gene therapies approved in the U.S. ever. So I think both the genome editing technologies and the genetic, our understanding of the genome is advancing, and we're advancing on the delivery side. So this is what will lead to hopefully a large number of therapies that are durable and address the root cause of disease.
Great. Manu, cystic fibrosis and sickle cell are both induced by the single point mutation, yet cystic fibrosis appears to have received more attention for gene therapy. Why is this the case? And then Vic and Sean, are there technical challenges that have limited gene therapy for sickle cell that account for this discrepancy? So we'll start with Manu first.
Yeah, that's a great question, Lorez. And it's one of those things that there's not a set agreed upon answer. But if you just look at the numbers, so for cystic fibrosis, there's about 30,000 people in the United States affected with it, about 70,000 worldwide. For sickle cell disease, 100,000 in the US alone, with millions worldwide. So if you look at an absolute number of patients that are affected, sickle cell is up there. But then when you look at, before this conversation, I went and looked at the annual reports of the Cystic Fibrosis Foundation, and then looked at the annual report for the Sickle Cell Disease Association of America. And what's interesting is the Cystic Fibrosis Foundation, again, cystic fibrosis is a terrible disease. Let me also make that point very clearly. But their annual revenue of 2017 was $136 million, which most of that from special event revenue, general contributions, and support from the public. For the Sickle Cell Foundation of Georgia, their total revenue was $4 million. 30 times less than the revenue of the Cystic Fibrosis Foundation, right? And if you look at where most of the Sickle Cell Disease Association of America's revenue came from, 3/4 of that was from federal grants. So you could see the resources with which these two organizations have to spread public awareness. And then I can't help but ask the question, who do these populations affect? What is the socioeconomic status of those populations? And how much are they able to donate and give money to solving these diseases that affect their communities? And this is why I think we have to broaden that out and make more people aware of how these diseases do affect other people that may not look like them, but are still just as dramatic.
Thank you. Sean?
Yeah, sure. And so I think piggybacking on Manu's comments, I think if you look over the past 10 years and think about the rate of new treatments and innovative treatments for both CF and sickle cell, I mean, clearly CF has outpaced sickle cell, mostly driven by small molecule therapies. I think then also early on, there was a considerable interest and talk about gene therapies for cystic fibrosis, but actually, if you look at the trials that are both enrolling and moving towards the clinic today, and on clinicaltrials.gov, you actually don't see any trials reflected in gene and cell therapy for cystic fibrosis. Instead, you do see quite a few, as I mentioned in my earlier comments, for sickle cell disease. So I think, again, this creates cautious optimism that there's momentum in the right direction around innovative treatments, and we remain hopeful. I think Vic can probably talk a little bit about the technical differences in addressing those through CRISPR and other approaches.
Yeah, so on the technical side, actually, I think at this point in time, at least, sickle cell has a lower hurdle in terms of the technical challenges than cystic fibrosis. So from a genome editing or a genetic strategy, we have two options for cystic fibrosis. We can correct the causative mutation, or we can augment the gene with a copy of the gene that does not have the mutation. For sickle cell, we can either fix the mutation, we can augment with a gene that's anti-sickling, or that replaces the gene with the mutation, or we have that third option that we've talked about, which is we can upregulate a compensatory gene that is elsewhere in the genome that's actively suppressed during adulthood. So you actually have more genetic approaches with sickle cell than you do with cystic fibrosis. And then on the delivery side, which is the other big component, there's been a lot of success, and there's a lot of understanding and an evolution of the stem cell itself, the stem cell therapies, and stem cell transplants. And so I think this is sort of in contrast to developing the delivery vehicles that are required either for systemic administration or for inhaled administration for cystic fibrosis. So I think overall, actually, sickle cell has a lower set of technical hurdles associated with it at this point in time.
Great, thank you. Sean, how does the payer mix influence the development of new technologies for treating sickle cell? And then how do we ensure, as we come up with these new technologies and or new drugs, how do we ensure access to populations that really need it but might not have those resources to get it?
Yeah, both obviously really good questions, and really the reason why we're here. I mean, I don't think what we don't want to do is develop drugs that nobody can get access to, right? So it's really twofold. So, but getting back to your first question around payer mix, in my experience, it hasn't necessarily been the discrete payer mix that has been the variable that's considered. Instead, it's really a combination of unmet medical need, patient population size, the value that can be delivered, and then the ability to get reimbursement. So, it's those combined that are really those non-scientific considerations when looking at it, which includes a facet of payer mix, but it's a little more complicated than just that. In terms of ensuring access, it starts with developing high-value treatments that really address unmet need in patients and delivering value for them. And I think the term value can be defined a number of different ways in terms of offsetting current or future medical costs, improving quality of life, or many other considerations depending on the specific condition. So really the onus on all of the stakeholders is to be able to establish the patient journey and a deep understanding of the impact that the disease has on an individual. And then as a drug developer, being able to show how our product impacts that patient journey. And so obviously I think the best way to do that is actually with people like Karen, who is generous enough to share her story. That is the patient journey. And it talks about how the disease impacts every facet of her life. And what we're seeking to do is develop treatments that create an intervention and a positive outcome for us. So establishing the patient journey, the value your product gives, and then being able to discuss that in earnest with payers will create the access we need.
Great, thank you. Mary, why is population health surveillance of sickle cell disease important as we talk about and look for cures?
Sure. So, it's so exciting to hear all of these things that are going on and to think about gene therapy and to think about all this research. But the reality is we still don't know basic answers about sickle cell disease. We don't even know how many people in the United States have sickle cell disease. So Manu said around 100,000 and we say around 100,000, but it's because we don't know any better. There's no systemic national system for even counting how many patients there are with sickle cell disease in the United States. And so population surveillance is at its fundamental, most basic level, looking to do just that. How many patients are there? Where are they? Where do they go for care? And the reason that data is so important, so those of us who look at data are just excited about data in itself, but it's really important for many more things than that. Having data is how you get resources to improve things for any disease. So if you need to show that more research needs to be done, you first need to show that there are patients who need research to improve. If you need to show that patients don't have good access to care, you need to be able to show that there are data that shows that there are patients living in an area that the area doesn't have a hematologist. It doesn't have anyone who's seen adults with sickle cell disease. And so that's why data is so important and why population level surveillance data in particular is important. This is capturing the entire spectrum of patients with sickle cell disease. So those from when they're born till when they die, people who are being seen in the top clinical centers in the country to people who, rely completely on the emergency department for their care. So really encompassing that entire spectrum of the patient population to be able to understand everyone with sickle cell disease, not just a select portion of the population.
Great, thank you. Karen, I have a question for you too. So a big part of managing sickle cell is trust in your doctor, trust in your provider. And, not all the things, as you talked a lot in the video about sort of how, if you were to tell doctors what's really important for people and patients with sickle cell, how do they, what will make them trust providers more?
The patients to be able to trust providers more is understanding communication, like communication between medications if they are or not working, or having communications between, like, if you're in adult care and you're having it's a month where you're having financial difficulties, but you need to get to an appointment. How can you communicate that with your providers? Because sometimes you might not have a way to get to your appointment. And so just communication and being able to trust that the provider can work with you with whatever life situation that you have going on. And being able to trust them that when you're telling them what is and isn't working for you as far as medications or how you are feeling, that they believe what you're saying, because sometimes you'll have a provider and you'll tell them you're feeling bad, and you'll get a negative response or disbelief, and that creates distrust between patient and provider.
Great. Thank you for sharing that, Karen. Manu, Africa and especially Nigeria has some of the largest burden of sickle cell disease in the world, yet access to basic care continues to elude most of the patients. How and what needs to be done to rally the kind of support and funds, as you mentioned before, HIV, AIDS, sort of there's maybe not as many available to those countries, but more than there might be of sickle cell. And so maybe talk about that a little bit, if you don't mind.
Yeah, no, that's an important question because that's where the burden of the disease is over in sub-Saharan Africa and parts of the Arabic world and the Indian subcontinent. Just in the United States, it predominantly affects African Americans. So it reminds me, I take back, I would encourage people who are interested to check out the work of Dr. Michael DeBon of Vanderbilt, who has recently started to do some really incredible work with sickle cell disease in Nigeria, where they do have the largest disease burden. But when I think about what is that difference and how do you translate it, I think there's definitely a big difference between a communicable disease or an infectious disease like HIV, where there's a risk of contracting it and which motivates different public health perspectives, than a disease that is non-communicable, that it's only transmitted through the germline, right? Like sickle cell, which is genetic and inherent. So I wonder if there's people who feel about safety and the need to tackle it in a certain way. But I also think that the knowledge about the global burden needs to be broadcast more fully because, again, the 100,000 in the U.S., presumably, as Mary said, we need to do a better count. But the millions are born worldwide, and the latest numbers I've seen show that up to 90% of these children can die in their first 5 years of life, which is a devastating statistic that motivates me and my lab to continue our work. And it's one of these things that I think letting people know that it still exists. I always think about it was one of the first diseases we learned about when I was in high school in AP Bio, because you've heard about it, it's a single point mutation, it follows Mendelian genetics, great to study. But then people are surprised that it's not cured yet. It's one of these things, if you don't know someone living with it or you don't have it in your family, then people forget about it. And I remember there was an article in Essence magazine a few years ago, and on the cover, it was really disappointing to me actually, because there was a little girl that they said, I think the sign was cure for sickle cell. And it was a young girl who was cured by a bone marrow transplant, which was true for her, but the messaging was just that there's a cure for sickle cell, and there's not. And even the bone marrow transplants, as I believe some of the other panelists have discussed earlier, it's not really a functional cure or practical cure. And because you have to find a bone marrow match, you have to find the right things, or terrible things can happen. But then the cost of that is also prohibitive for places like Nigeria and other places in the world. That's not going to be a sufficient solution. And so I think we need to watch the education of what's happening, watch the miseducation of what the options are, and make sure that we talk to others and let people know that this disease burden is real. And we should promote those groups that are taking this work to international communities. And I think that's one of the biggest differences, I think, between HIV and sickle cell. It's about, well, I can't get it just from being over there, but I still should care about the people that it is impacting.
Thank you. Mary, there was a follow-up question to when you're talking about the numbers of people impacted, and Manu, if you want to jump in afterwards as well. But why is it so difficult to assess the number of people affected by sickle cell? Is it due to a lack of access to healthcare, or for something to happen, or why is it hard to put a number around that?
The very blunt answer, the reason it's hard to put a number around that is we have no system in place to count the number of people with sickle cell disease. So So there's just, at this point, there's no system in place. There's nothing equivalent to a cancer registry or a registry for ALS, or there's registries for many other diseases. And that type of system just does not exist for sickle cell disease. What we do have, or what we could have a fairly good handle on, are the number of children born with sickle cell disease in the United States. And that's because all states now have universal screening for sickle cell disease in the newborn period. And so that's a great start. That number is still not captured in any way for the entire United States, but it could be. But where the real challenge is are people, again, as I said, who were born in the United States before newborn screening was implemented. So the last state to bring on newborn screening wasn't until 2006. So everyone born in that state before 2006 would not have undergone newborn screening. Also, we obviously have a large population coming to this country from other parts of the world. And so they're not going to be captured through newborn screening programs. So because not everyone living in the US will have undergone newborn screening at this point or at any time in the near future, there needs to be a system in place to do a better job of capturing national data.
Well, can I jump in real quick, Laura? Almost with a question for Mary. So I do a lot of work with the Sickle Cell Foundation of Georgia, and what they always remind me of, which is really important, is stigma, and how if you start identifying people and capturing people, there's a risk of stigma attached to those people. And so I was, as you were telling us about this issue with cataloging people, I was thinking about if you follow people with sickle traits, those are the carriers that have the potential to pass it on to their children. But then I got concerned about stigmatizing people with sickle trait. I just wonder how you think stigma among this population affects them, quote, coming out to be counted and to be registered so that appropriate resources could be allocated to them. I'm just curious.
Sure, that's a great question. So the work that we do in CDC and our surveillance program, which is, it's only in 2 states, but it is working to count people. There is no patient input into this. So this is a program, it's all passive surveillance. We are counting people through data sources that already exist. So there's no new information being collected as part of our program. Rather, we're compiling information that already exists. However, there are other programs. There's a patient-powered registry that the Sickle Cell Disease Association of America, the group you mentioned earlier, is spearheading. And that is a registry where patients, family members can self-identify, go to a website and input their own information into a registry. The last that I heard, there's about somewhere around 5,000 patients that have chosen to do that. So there are efforts like that. They're kind of it's a different effort than the one that we're doing with surveillance, but I can see that in the future there are certainly ways for these efforts to be complementary. As far as stigma, that's a really great question. I think stigma is an underlying part of pretty much everything we can talk about when it comes to sickle cell disease. And I see no reason that the reason that we don't have a better count of numbers or have more robust registries isn't also probably related to stigma from different levels.
Great, thank you. So we'll probably have time for about 2 more questions. Vic and Sean, I'll say, sometimes people look at technology as being very costly. So it can be that sort of gene therapy pharmaceutical piece. Is there a trade-off? As we make more advances in technologies, do we see less production in drugs or the other way, or is it they're not connected at all?
Sorry, Lorez, can you just say a little bit more about the question? I didn't
Sure. I think one of the questions we got from the audience was really related to, as we make advancements in technology, that sometimes that's at a high cost, and that discourages pharmaceutical companies from pursuing other alternatives. And so it was a question, how much of this is reality, sort of, or is that just a perception, or do they play together?
Yeah, I mean, I think they do play together, and I think we're seeing it even. Let's go back to the CF example that we talked about earlier, right? I mean, there are established products out there for CF that do treat subsets of the population, but there's continuing scientific advancement for CF. Obviously, as we discussed and have discussed throughout the panel, sickle cell hasn't been a focus for a while. So I don't think it's as a great example for sickle cell, but what you can see is that there is quite a bit of activity and advancement. And look, some people talk about cures. We talk about effective, durable treatments. I mean, the actually curing disease is not where we are today, but creating, valuable products that create durable outcomes for patients is what we're trying to do. And I think in the face of that, you'll continue to see advancement.
Yeah, and maybe just to add on to that, I think what you see in general in technology space is as technologies become successful, they're always expensive in the beginning, but what you end up getting is refinements, improvements, standardization, and broadening of those technologies. So ultimately, the hope, at least from a technology perspective, is you drive the cost down.
Great, thank you. And as we talk about the patient, Karen, I wanted to give you an opportunity to just share with people, we've talked a lot about the data and the science, but as somebody that lives with sickle cell, what's important? What do you want people to walk away from this conversation with?
I would say I would want people to walk away.
We might have lost Karen there.
No.
So Manu, maybe let me just say from your work with the Sickle Cell Foundation, what is it from a patient perspective that you think it's important for people to know?
Well, I would probably want to give echo to Karen's words from earlier that doctors should trust the patients, and that will improve the trust that then the patients have with the doctors. I remember when we did the pre-recording, I think that was one of the most astounding things that she did say. And then the benefits come far beyond just the trust and just the treatment becoming better. But as she mentioned, that helps those of us on this panel that are involved in the research aspects. Maybe our studies are off because we don't have accurate information. And that's because there's this mistrust between the patient, the doctor, and or the researcher. And so I cannot speak for Karen, but I would think listening to the patient or listening to the person living with the disease is probably something we should all walk away with.
Great. Well, thank you. I want to thank all the panelists for your time. I want to thank all the participants for joining us and being part of this virtual Keystone Symposium e-panel event. A recording of this will be available on the site. And for additional information on Keystone Symposia, please visit www.Keystone Symposium. And so again, thank you to all. Thank you to Karen. Thank you, Karen, for being a part of this.
Yeah, sorry, I got disconnected. No. I apologize.
No. Well, and if you want a last word about Manu's just reiterated the importance of trust in providers, the importance of listening to patients, the importance of getting accurate data is really important. And so if there's anything you want to add to that, we welcome that.
Another thing that Manu said in the video was at the end of the day, we are human. So a lot of the times you'll have where data is very important, but sometimes some doctors will treat the data as if the data is you instead of treating you as a person. And they'll look at it and be like, well, data's here, shows that you're not sick. And then start advice actually. Finding the silver.
Thank you. That is a perfect way. Yeah, that is a perfect way to end this symposium, Karen, is to remember that data, science, all important, but it does come down to people and people living with the disease, and how do we work together to find ways to lengthen life and find cures. So again, thank you to everybody. So appreciate your time. And again, you can find a recording of the symposium on www.keystonesymposium.org. Thanks so much, everybody.
All right, bye.
Thank you.